Okay, so part 4, we're going to get into golfer's elbow, which I think you're probably familiar with. RTS, radial tunnel syndrome, which you probably aren't familiar with, as well as bicep rupture, kind of FYI on that one. Golfer's elbow, you need to know this. It's kind of just the opposite of tennis elbow. Tennis elbow is on the lateral epicondyle. Golfer's elbow is on the medial epicondyle. And in this case, it's the wrist flexors, where they all attach. A lot of them attach right there in that condyle, the medial epicondyle. That's where it gets sore. That's where the pain is. It's from repeated wrist flexion. So this wrist flexion is how you test for it as well, as you would imagine. So basically, just resisted wrist flexion will give you a positive golfer's elbow or medial epicondylitis test. You aren't really resisting it here, he's just doing it, which in a lot of cases will probably provoke it by itself. But he does the wrist flexion. As a therapist, you can resist that, and they will say, oh, it hurts right around the medial epicondyle, and you go and confirm it with your thumbs, palpate, and sure enough, it's very sore in here, and then you can, that's what they got. They have golfer's elbow. We'll talk about the treatment in the treatment box in a minute. Radial tunnel syndrome, or RTS, can be very confusing because it's very similar to tennis elbow. In fact, the tests for tennis elbow and RTS are the same. They'll be positive. They'll all be positive. The Cosen's test will be positive for RTS and tennis elbow. This is the middle finger test. She's extending her elbow, sticking out her middle finger. He just presses down on it, and it hurts. It'll be positive for tennis elbow and RTS as well. So how do you know which one is which? Again, you follow your thumbs, you palpate, listen to the patient. Where are they feeling this pain? Tennis elbow usually is right on the condyle. RTS is more distal from the condyle, further up a little bit, right in this area is where they're going to be hurting. And with the radial tunnel, a lot of times they're feeling it when they're doing work-related activities like pronation, supination, along with that wrist flexion. And then just lastly, this is just FYI, it won't be on the midterm exam. Proximal bicep tendon tear or rupture. You see this once in a while, and you're kind of wondering, what is that? And it kind of gives like a Popeye kind of thing after it tears. And what happens is, like when somebody has a severe case of bicep tendinitis, as we know from earlier, that goes right through the bicipital groove, and it frays and frays, and eventually it will just rip right off. And when it does that, that long head of the bicep just pops right out. It looks like this. And kind of looks like a Popeye kind of muscle. It should look like this person. They've torn both. No, that's slow touch. This one kind of tore off. And strangely enough, it sometimes really isn't that big a deal. You can have surgery to go back and repair it, and there's indicators when to do the surgery, when not to do surgery. But eventually it just kind of disappears. It just kind of gets absorbed in the body, and the short head and the brachialis kind of compensate, and a lot of people don't really know the difference, mostly if they're older and not doing heavy construction work or that sort of thing. Okay, so let's just go, if we can, to those treatment boxes. The elbow. Here's RTS. Talks about the test. There's the middle finger test. This one, unlike tennis elbow, it's really hard to treat. Tennis elbow, every time I've had that as a therapist, I was able to get rid of it with the Mulligan lines. And there's a lot of evidence-based stuff that really works well for tennis elbow. Not so much the case with RTS. In fact, if you look critically at the literature, there really is nothing that's definitively works. What do therapists try? Common things that make sense. Activity modification, ice, posture. Posture is a good one with here because it is a nerve. The radial tunnel, it's a radial nerve that goes through there. So if somebody has poor posture, it could be a pinching irritation coming down, through the plexus and the outlet. So posture could be an issue. Splinting, how do you splint? The splinting itself is controversial. Sometimes it works, sometimes it doesn't. You're trying to splint them into a position that rests that radial nerve, basically. And how you do that, you stick them in 90 degrees of elbow flexion, get the wrist around 20, 30 degrees of supination. how much can they tolerate of this is a difficult thing. It's quite restrictive as a splint. And you definitely got to get them out there every hour or so, extending their elbow so it doesn't freeze up. You could also just try a wrist cock-up. You could try a counterforce brace. Radial nerve glides may work since it's a nerve issue. You could try ultrasound, ice, that sort of stuff, isometrics. It is challenging to get rid of, but here's some ideas that make sense biomechanically. Golfer's elbow, medial epicondylitis. Painful wrist flexors. We talked about the test for that, the golfer's elbows test. This also can be very hard to get rid of. Unlike tennis elbow, you think, oh, it's just on the opposite side. Same thing should work. I should be able to get rid of it. You can try the same things. I'll definitely try everything you can think of. Mullican glides, there isn't evidence that they work for golfer's elbow. I've tried it repeatedly. I've not any luck with clients with golfer's elbow. Try different massages, ice, heat, pulsed ultrasound, adapting things, different kinds of braces, counterforce braces, isometrics, similar stuff. So if you get the tennis elbow stuff down really well, you know that you're doing similar stuff for RTS and medial epicondylitis. And then here's just the rupture. This is just FYI stuff. It talks about how to determine it and some exercise ideas if you do see some of this in the clinic. Okay, that is that one, I believe.